Good evening. Thank you for joining us today for our Why Diversity Matters in Medical Research panel. I'm really excited to be here with y'all today and even more excited to help facilitate this conversation with these amazing doctors that are here to speak with us today. Before we get started though, some quick housekeeping. This event will be recorded and shared with a wider audience in the near future. The chat function has been disabled, but additional questions may be asked through the Q&A function. However, we have had so many questions submitted in advance that it is possible that your question may already be addressed in as our conversation goes on. Because they have been so many questions and because this topic is so important, we might run out of time. But if that happens, we will respond to your questions in a follow-up email. As this is a Zoom webinar format, only the panelists will be visible to the attendees. Attendees will not be visible to the panelists, although we wish we could see all of y'all's wonderful faces. So without further ado, let's get to know who our panelists are today. Dr. Salloway, can I have you introduce yourself, please?
Sure. I'm Stephen Salloway, and I direct the Memory and Aging program over at Butler Hospital. I'm a professor in the departments of neurology and psychiatry at Brown. Do you want me to go on from there?
Yeah, tell us a little bit about what you do.
Well, first of all, thanks, Giselle, and thanks to the organizers for including me in this important program. I really look forward to learning together. So my focus is on Alzheimer's disease and research, and as many of you know, Alzheimer's is a major public health problem and is really an epidemic that's occurring within the pandemic that we're experiencing as the population ages. And it doesn't affect communities equally. So African Americans and Latin communities have a higher rate of Alzheimer's and dementia. We don't really understand all the factors that contribute to that. And it's important that we do, because we want to know what's causing the memory loss and how best to do it. It turns out people of color participate in very low rate research and way too low, and also come at very low rates for clinical diagnosis of memory loss. There's some stigma about that, and there's a reluctance that we need to overcome. And it's now a priority for medicine that the populations that we study for research really reflect communities that we serve. So, and what's going on. And
definitely.
True in Alzheimer's, and Brown is really embracing here tonight. We're building a major research in Alzheimer's at Brown. So there's a big commitment right now from the president to the dean to our head of brain sciences, and going to involve faculty across the university and the medical school hospitals. We're really excited about it. And we want it to be inclusive. We want the that we do to really reflect the population that we serve. So we're going to big, it's a real priority. Now,
awesome.
It's a major league undertaking, because there's so much reluctance that's built in, inherent, that we don't understand. And we have to build the trust and a community and an environment of care where people really feel, doesn't matter your background, feel like they're going to be cared for well. Their needs are going to come first, not the need of the research study. Our research participants that come over to our memory and aging program feel that way, but we don't have very high participation from communities of color. It's not a diverse group of people, economically, ethnically, racially. And so we need to do better. And so some of the things, we'll talk about this tonight when we get into the questions, just to give a teaser. I mean, some of the ways we're going about this is to actually set up sites in the community. So people don't necessarily have to go to our hospital, which is out of their normal travel area, where comfort zone. They actually can have the clinic or some kind of clinic that's in their community program like Progressive Latino, and they have staff members, health educators that are part of their community, and they can actually do a way better job of hiring people, staff, clinicians that reflect the communities that we're serving. And we're trying to do that. We need more help. We need more resources. It's not built into research grants. Happy to say, Giselle, that we now have 6 major NIH studies that emphasize diversity of recruitment. And so that's a priority. So and some of them are actually providing some resources so we can hire staff and create some of these satellite clinics in the community and so forth. So
I'm gonna have you stop there so that you don't give too much
away
saying, of our questions, and so we can get our finalists.
My last line, I promise, is what I really hope to learn, because this is something new. I'm not an expert in diversity recruitment, but I'm committed to it, and our program is as well.
Thank you for that, Dr. Salloway. I'm going to have Dr. Wilson introduce herself next, please.
All right. Thank you so much, Giselle. Thank you to Kayla, and Kelly, and Ellen for having us tonight. Good evening, everyone. So my name is Taneisha Wilson, and I'm an assistant professor of emergency medicine at AMS. And I also serve as the director of equity initiatives for Brown Emergency Medicine. So when I'm not teaching or doing clinical work, I use the remainder of my time to highlight inequities in the delivery of emergency care to particularly vulnerable patients. And currently, I aim to improve the emergency department experience of patients with sickle cell disease. And so diversity matters in research, period, right? I don't think I have to sell this to this crowd.
Period.
But I know some folks are thinking, this may be a little bit of a counterintuitive point to make, because we're currently at AMS highlighting the fact that race is a social construct and not a biologic construct. However, as Dr. Chandra Ford, a professor at UCLA, highlights, race is less a risk factor itself than a marker of a risk of racism-related exposures. And so for this reason, it's crucial that we ensure that all studies, particularly those geared toward the emergency care of patients, have diverse representation. And I kind of want to get into a little bit of the NIH Revitalization Act that was passed in 1993 that mandated the participation of women and minorities in research for the very first time. And this was amended in 2001 to ensure that there were reporting of these analyses that were done. And the FDA in 2016 had a year of diversity in clinical trials where they kind of highlighted the fact that clinical trials weren't as diverse. And we know this for a fact because we know that African-American men are 2 times more likely to die of prostate cancer, right? But they represent only 4% of prostate cancer, of patients with prostate cancer in clinical trials. Now, how does that make sense? We know that African-American folks or Black folks, folks who identify as Black, comprise about 12 to 14% of the US population. So 4% in a research clinical trial does not quite make sense. Just one more, Giselle, just one more. In 2014, suicide was one of the top 3 causes of death for Asian American women ages 15 to 45. But only 2% of participants in clinical trials geared toward major depressive disorder had Asian American patients in them. Asian Americans make up about 6% of our population. So 2% is not, it shouldn't be, right? The NIH shouldn't have let this happen. So we need to ensure equitable participation of all patients. And what that means, I argue that means that every study, randomized clinical trial should reflect the demographic population of the local area or the US. And if that isn't happening, then the funding organization should sort of step in, right? So I'll leave it at that for now, and I'll turn it back to Giselle.
Thank you so much, Dr. Wilson. Now I'm going to have Dr. Dizon introduce.
Well, I'm just happy to be here. Thank you very much for putting this on. I am I wear several hats, both locally and nationally. So I am the head of the Breast and Pelvic Malignancies Program at Lifespan Cancer Institute, and direct the community outreach and engagement program for the Cancer Center at Brown University. On a national level, I serve on the ethics committee for the American Society of Clinical Oncology, and they're representative to both the health equity and the LGBT, or the sexual and gender minority task force within ASCO. And then within something called the National Clinical Trials Network, which is where NCI-funded cancer clinical trials are undertaken. I'm the chair of digital engagement there. So much of my work recently has been focused on issues regarding intersectionality as well as equity and the inclusion of sexual and gender minorities into the profession as oncologists, to be more welcoming to people who are not appropriately represented in clinical trials, just like Dr. Salloway has stated, and also trying to address both explicit as well as implicit biases within oncology, and get to the hearts of misinformation that may be preventing people of color, as well as SGM folks, from seeking care in a more timely way.
Awesome, thank you. You said one of my favorite words, intersectionality, because I think that that's one of the words that, if we keep in mind, makes us much better physicians, well, for me, physicians in the future. Mm-hmm. And also, I'm gonna quickly introduce myself in case y'all were wondering who's this other person on the other side of your screen. My name is Giselle Bello. I am a fourth-year medical student here at Brown, serving as the Diversity, Equity, and Inclusion Fellow for the Office of Diversity and Multicultural Affairs. I get to be here not only because I'm a fellow, but because I really care about this topic as well. As an Afro-Dominicana, this topic is near and dear to my heart. Because I grew up in the projects and had direct contact and have witnessed health disparities in communities of color. And really, that's one of the biggest reasons why what brought me to medicine. So in our planning for this panel, we found ourselves sharing a lot of the things that were just shared right now as to why this work is individually important to us. And one of the statistics that came up in our conversation was sort of mentioned in y'all's introductions, is that 89 to 98% of those participating in research studies across the country are Caucasian, non-Hispanic. And being that the United States is such a multicultural country, that should be striking to y'all too, as much as it was striking to us when we were having our conversation. So to get us started today, our first question is, can you provide some tangible example of how y'all have seen the lack of diversity affect research and or patient care? I'm gonna ask Dr. Wilson to start.
So while I must say, I in our emergency department, because we do see such a diverse patient population, from a research perspective, we are very fortunate in that we enroll in the emergency department because we do emergency department studies. Now, a lot of our colleagues do rely on us to help them enroll their patients for some outpatient studies. And if your initial pilot study, for example, doesn't take into account the fact that a lot of your patients might have difficulty accessing your resource, for example, coming into the emergency department for blood draw, or, coming in for the follow-up to do that clinical scale or clinical score that you've implemented, you can have a significant amount of kind of dropout, right? And then the question becomes, the patient's not interested in doing the research, but really what happened is what's happening in that community is that patient population is actually servicing our entire community, our entire little state, right? They're going out to work and taking time off, and we'll say, and I think a part of this too is that we often think that research studies go much quicker than they do, right? We'll say that you only need about an hour off from work. You can come during your break time, but really the RAs need time to get X, Y, and Z, need to get things plugged in and ask questions. And then it's 3 hours and the patients kind of learn that. And so they're not going to come for the remainder of the follow-ups, right? And so you're trying to implement a process and procedure And because you haven't taken into account the needs of the population that you're serving, then you ultimately have so much dropout. And then the perception is that the patients aren't interested. And then you actually lose the patient population that you're interested in studying because of multiple barriers to their care. And so from emergency medicine research perspective, because we do emergency research, I can't say that ultimately we have the same limitations when it comes to follow-up, but when we do try to help a lot of our colleagues with continuing that emergency department care in the outpatient setting, there are multiple barriers to that, and especially when you do have to think about that when you're designing your study and caring for that patient population.
Awesome. I think Dr. Dizon unmuted, so do you have something to say about this as well?
Oh, no, I mean, I think, it's probably most obvious in the research realm in the approach to the patient who's a candidate for clinical trial but doesn't speak English. Usually there's one of two reactions. Either you don't present the trial because the person doesn't speak English and it takes too much time to get a translator in, or you take the shortcuts, and the shortcut might be, oh, well, you're here with your daughter who speaks English, so let me tell your daughter about the trial and she can translate for you, which is, we all know you're not supposed to do, because siblings, children are not in a position to explain a study objectively most times, especially when their parent is dealing with a very life-threatening illness like cancer. But also the language of consent is exceptionally technical. And to assume that anyone without a medical background or any medical exposure can translate a consent form is really not reasonable. But the other alternative is you would go through the consent process, presenting everything orally, giving an opportunity to provide questions as you would. But the departure point is that for someone who does not speak English, in whom there is not a consent that's written in their language, they can go ahead and sign what's called a short form consent. And that short form consent is nothing comparative to what someone who speaks English gets. Now, in oncology, especially with new drugs, you're explaining mechanisms of action, what you know about the drug, side effects of the drug, the schedule of assessments. It's exceptionally long. Our consent forms are anywhere between 20 and 45 pages. And that's for someone who speaks English. So the alternative for someone who does not speak English, in whom there is not a consent form in that language, is you do the same thing, but you do it orally, and they go home with what's called a short form in their language that says, I have explained everything to you, and you are still willing to do this study. It's not anything that any of us feel is terribly useful, but in a quest for a more diversified group of people who represent the US population, and given, and I think we will all agree, the ability to create consent forms in every potential language that our state serves is not practical at all. This is a solution, but it is a very critical barrier that we face in oncology.
Yeah, I can pick up on that. So 3 things come to mind. First is what Don just said. You need to have the information accessible in a language that the person understands, and with people who speak that language and also understand the cultural issues or the concerns that the participant may have. And we don't readily have that. It's a lot of extra work and it's extra expense, but it's really important. So we're going to need to, as much as possible, build that in. So that's something that it's a work in progress, but that's a limitation. Another big one within the Alzheimer area is that a lot of the stigma about Alzheimer's is like, it's something that's either a defect in you that people don't want to acknowledge, even though it's a medical condition, or it's just part of aging that you can't do anything about. And so they don't want to pay attention. So a lot of people keep their family members at home and don't bring them for never mind research, don't bring them for medical care. So we have to do a lot of education about what Alzheimer's, what memory loss is, what's normal. It's not normal part of aging. It's very common. It's not normal part of aging. And understand the important, like all areas of medicine. My big goal is to bring Alzheimer's into the modern era of medical care, like every other. It's a chronic medical condition. It's really important. It has a big impact on patients and families and huge healthcare costs. And we need to do a way better job, and we need to start early. And now we have better tests where we can detect people who are at risk for Alzheimer's even before there's any memory loss. So we want to get in there way earlier than we are now. And that's going to require a lot of education, but especially in different community, every community has its own apprehensions and reluctance. And so we have to address those. I have another issue, but I'll bring it up later.
Yeah, so we got the examples of from Dr. Wilson about forgetting about the barriers that patients actually go through in order to enroll into studies and how much time it takes away from them. Dr. Dizon told us about consent forms and not having them in the appropriate language, which as someone who worked as a research assistant before, I know that consenting someone for anything, let alone reading it to them and thinking that they're gonna go home and remember everything we've said in that technical language of consent seems so just not great. And then lastly, we heard from Dr. Salloway about that there's real stigma around research, which is a perfect transition to my next question, which is, how does an awareness of the historical and contemporary mistreatment of African Americans in America and in American medicine translate to creating a stable and trustworthy environment for our African American patients in medicine right now?
I can speak from the oncology perspective. It's a really interesting thing to talk about a study on a one-on-one basis. If someone has cancer, African American, and I'm speaking to that person alone, there's more often than not there's deference. You know, whatever you say, doc, this sounds great. I trust you completely. But I realize that no one is going through this experience alone. And this person is going back to her community, whether that's her home community or of her husband and maybe, or of her children, or maybe her child who has a medical background. It might be her church. It might be her neighborhood. But people are informing that decision. So I think it gets to Steve's point. We need to understand the community. We need to understand that how the community is not only interacting with each other, but how are they influencing each other? Because I think this is where a lot of the barriers may not be stuff that I understand as a clinician, and it's not uncommon. I think for any of us where we will discuss a study, it will be received positively, but I tend to send people home and say, why don't you look things over and then come back? And if you want to do this, we can sign the consent form. I try not to do it on the same day, but a lot of people will come back either by themselves or with somebody else and say, no, I don't want to do this trial.
Well, I think to answer your question, I think it's huge. I think that's the main problem, that there's been mistreatment in the past. Some of it has been flagrant, and that it's in people's psyche, what happened at Tuskegee and other places. But there are many other occurrences that are much smaller, but that also contribute to the apprehension and the reluctance. So the trust issue, I think, is fundamental. It has to be, we have to have an environment of care where, as I said before, where people feel like their needs are going to be first. They're going to be treated well. We really care about them as people, and it's safe. And the advice we're giving them is in their best interest. And I think for right now, for what Don was saying, I think we really need to elicit trusted community leaders who can carry that message to their communities and help serve as a bridge so that people feel more at ease. And we obviously have to be engaged with those leaders. And one of the biggest things for Alzheimer's we can do to start things rolling in the right direction is open discussion, because it's not something, it's like cancer was 30 years ago before there were more treatments. It was something that was, people were very reluctant to talk about. And still people are very reluctant to talk about Alzheimer's because they feel the stigma associated with it. And so we really need to open that dialogue. And I think community leaders can help move that forward.
I absolutely 100% echo that about involving the community and community leaders. I think something that we definitely have to keep in mind as we consider that involvement is, again, the time and costs that a lot of these studies are associated with, right? Because it's not just a simple thing to have, to train and teach community leaders. It's their own time, it's resources. So I think injecting some of our, university research dollars into the community absolutely makes sense, so we can kind of create that foundation for when all of us do need to tap back into the community and the community leaders to say that we do need that help. And I think the NIH is maybe on board with that based on the recent funding opportunity announcement that just came out today regarding identifying structural issues with structural racism and funding grants that are specifically geared toward dismantling structural racism, both with hiring researchers and providing resources into communities. So I think that cannot be said enough, Dr. Salloway and Dr. Dizon. Thank you so much. It cannot be said enough.
Well, I just want to add, I think we need to build on what Taneisha just said. I think we need to put resources into the community. And also I want to underscore what you said, Taneisha. Our studies, and I'm sure the cancer trials are the same, are a big commitment. And usually it's many years, and it's a big commitment. And so it's not a minor, many of them, some are smaller, but many are, it's not a minor undertaking. And I think we have to in order to form this partnership, we have to put resources into the community. Because the community has needs, but for care, I'll just take Alzheimer's. I mean, to care for those affected with Alzheimer's in their community, because the resources are usually inadequate. And so we need to put some of those resources in there to address some of those needs. I don't think we can just go in there and ask, oh, gee, would you like to participate in our research project? Even if they might be interested, there's so many other needs that need to be addressed as well. I think they're going to be more interested if they feel like we're contributing, we're really a part of their community and supporting their community. And then at some later time, we're going to be more able to form a two-way regarding research.
For sure. And so as we heard, in order to sort of create some of that stable, trustworthy environments, we need to understand the community and how they're influencing one another, especially in making this decision around whether or not to be involved in research. Involve trusted community leaders to serve as a bridge and facilitate these open discussions, but also understand that it takes time, there's costs, and a lot of resources that goes into research studies. And so injecting money and dollars into the community to help address some of those mistrust issues. And so now that we've spoken a little bit about just mistrust issues, what can medical research institutes do to encourage diversity in clinical trials if currently there is this mistrust and sort of unequal equation when it comes to the community and how they feel about research? I'm going to have Dr. Salloway start on that one.
Well, what can we do to make it better? To build that?
What can we do to medical research institutes do to encourage diversity in clinical trials?
Right. Well, I think having faculty and clinicians and research staff that are from those communities that people can identify with really is going to help. And also based in the communities as much as possible, or serve as maybe as a bridge between the research program and the community program. You know, having a social worker, I mean, for us, or a patient navigator or a participant navigator is in sort of a new idea in research. I think cancer has this more experience with this. I think that could be a real support for patients and help the research as well. So both will benefit. And then also looking, you know, I think Taneisha brought this up earlier about what are the dimensions of diversity. I mean, there's a lot of factors that go in, but education, we tend to have a very highly educated group of participants, so it's not reflective broadly of our community. We have more urban, very low rural participation. We have higher socioeconomic status. I mean, so it's not just race or ethnicity. There are many factors in order to be inclusive. So we just have to think more broadly about diversity.
I can add, Dawn, if you're not going to go yet. So when I think about some of the barriers to our patients who are, you know, poor, vulnerable, have limited English speaking proficiency, some of those barriers include financial barriers. And while, because of, you know, our past research experience, we don't want to be coercive in the remuneration we provide to patients, right? It can't be coercive. That's just that would be an IRB no. I think it's reasonable for us to think about where we meet the patients, right? For some of our research studies, it might be helpful for us, you know, not COVID times, to go to the patients' homes instead of having the patients come to us if that's possible. Go to the community health center if that's possible. Go to the school, you know, where's the casino again? You know, go to where our patients actually are and, you know, actually meet them where they can meet us, right? Is it Kennedy Plaza? I feel like, you know, like I said, a lot of the barriers that we sometimes encounter when we're enrolling patients in especially long-term research, long-term follow-up, is that the patients they can't get to us. And so we have, you know, a high dropout rate. So maybe meeting the patients where they are, in addition to embedding ourselves in the community, I think would be a very good start to ensuring that we do have diverse studies.
Dr. Dizon,
Yeah, I mean, I think, sure. I mean, so on a national level, there's this rethinking of how studies are even designed from the start, from time zero. So in this group that I'm involved with called the SWOG Cancer Research Network, for example, they have over 40 patient advocates who are engaged in their studies. And they're both, you know, patients turned experts in their cancers, but they're also community experts or community advocates that represent the adolescent and the young adult community, the gay and lesbian community, you know, the Hispanic and the Black American communities. And these are not people who are trained in science. These are people who went through their own cancers. And the goal of these advocates is not to sort of put their rubber stamp on a trial after it's been written. They're actually involved from the start. You know, what's the objective? What are the objectives that matter to patients going through this? And how is this scheduled to the points mentioned? You know, do you really need to see this person every 2 weeks on this trial? That could be difficult for the person who's traveling 3 hours away. These are things that we as physicians may not think of. So I think engaging with patients as partners is critical to addressing the mistrust. So, you know, having them at the table, not as the recipient of research, but actually as one of the creators of a trial is a really important step towards better engagement. At what we heard at Brown as we're trying to form the Cancer Center was how important community outreach and engagement is supposed to be in the mission of your cancer center. You are supposed to meet the needs of your community, and those needs are supposed to be determined by the community. So, the charge of new comprehensive cancer centers is to engage, to set the research agenda, to set your research priorities, and to set the pillars of your cancer center, rather than these are our pillars and it might benefit our patients, but nationwide we are going to make a difference. That's not the case for funding of a cancer center. It literally is, how are you engaging with your community in the setting of your priorities, in the design of your trials, and the resources you're putting in. And we have some work. So, there are multiple systems. Hopefully a lot of them will coalesce to these, the Brown Allied Health System, right? But at Lifespan, even though, Black Americans constitute I'm looking here, 8.5% of the population, the cancer center at Lifespan was seeing 5% of its population were Black Americans, and the Hispanics constituting almost 20%. We were seeing less than 10% of that population coming to our cancer centers from those ethnic backgrounds. I'm not even going to say communities, because there are different communities even within those ethnicities, right? So we need to understand why that is and how can we make that better, because we also know that certain cancers are far more prevalent in some of those communities. And the question is, where are they? And if they're not receiving care, why aren't they? So again, the community informing what we're doing as a center is really the charge from the NCI.
I'm gonna borrow that idea, Don, from you. I like about the advocate, because we formed a community advisory board to help us with outreach that reflects, has community leaders, good representation. But we're starting a new prevention cohort for Alzheimer's, hopefully with our colleagues over in Sweden who've been doing this for a while. And I think it would be good to have that community board review the protocol, because we're just constructing it now, and give us input about how to, how it feels to them, and where the pain points might be for people, and to make it more accessible. So that's a good, I think that's just a great tangible example of a partnership where people are weighing in, and it's not just being handed to, here's the 40-page consent form, but actually
Right.
their input on the constructing that protocol and the consent. That's a great.
Right. And, the other thing about all of this is sort of, not treating advocacy work and people who are helping us do our jobs as free labor, right? It's like they are experts. They deserve to be compensated for whatever that is. And no one is doing these passion things, whether it's Alzheimer's, whether it's, being that person to say the emergency care is critical for X, Y, and Z, or for cancer. These advocates are working because it's a passion that was hoisted upon them. But we shouldn't treat that as free labor either.
So do you pay the advocates?
So at the NCI, they are paid. These advocates are compensated. There's a chair that actually gets a stipend, and then everyone's time at this is pre-COVID, everyone's time to travel to our biennial meetings, including hotel rooms and all that stuff, those are all compensated. Yeah.
Okay.
Just exchanging ideas here. And so just to recap, we heard from Dr. Salloway that maybe matching research assistants, social workers, and patient navigators to match a little bit more what our study population might be helpful. Dr. Wilson, again, reminding us about the barriers, mentioning specifically financial barriers and our patients not really being able to get to us to be able to participate in this, in research. So meet them where they are. And Dr. Dizon just mentioned the importance of having the community be a part of the study design from the beginning and not necessarily just the recipients of the research. And so wanting to transition a little bit, we got a question that's more around the sort of nitty-gritty of research. What are your thoughts about clinical research studies which specifically ask for race or ethnicity within the study? And I'm going to ask Dr. Dizon to start because you gave me a smile that makes me feel like you have a lot to say.
Well, no, I mean, I think, you know, in my lifetime, we've gone from calling everyone African American to Black American. And now we realize that Black American is still too big of a bag, right? And to assume that all Black Americans are the same Black Americans is really not correct. So if anything, our collection of demographic data, which is required as part of federal funded research, you have to collect ethnicity and race, but I think it's oversimplified, if anything. And as far as other diverse populations, we are not collecting gender, and we are certainly not collecting sexuality in a way that is informative. So one of my bigger initiatives that I've gotten involved with more recently is to make more transparent so we can understand outcomes of sexual and gender minorities. You know, there is nothing known about the experience of cancer and cancer therapy among transgender individuals who may be taking hormone therapy for gender affirmation and might have a cancer that is also hormonally driven. We have no idea what their outcomes are like. So I think it's still in its infancy, in my own opinion.
You mean that just categorizing people by race doesn't give you all the information you need for research?
No, I think it allows, so it's sort of like how we're classifying cancers on a molecular basis. There was a time when all breast cancers were the same. Now we know there are at least 4 kinds of breast cancers, but even if there's one type of breast cancer called triple negative, there's at least 5 types of triple negative breast cancer. So we are further along in the molecular characterization of cancer than we are in our collection of race and ethnicity.
I don't know what to do with that besides shake my head.
So, you know,
go ahead.
I didn't mean to interrupt. I was going to say, that, you know, I really started off with the, you know, using race as biology, I think is, again, too small. It's just not where we are. And, you know, skin color really isn't going to predict really how you respond to a medication. However, racism might, right? Where you live, where you've been redlined to like grow up and spend the rest of your life, and, you know, where you are mandated to work because of your ancestry, right, does affect, I think, your outcomes. And so getting rid of our current designation, I'm not sure we're there yet, but obviously we need to think about it, because I think your skin color doesn't matter if you're a Plavix responder or not responder, right? So there are things that are genetically based but have nothing to do with skin color per se, but it's really important for us to identify those differences. But while we work toward being an anti-racist society, I think the structures of racism remain, and those structures are pretty heavily dependent on the color of your skin as things stand, right? And a little bit your socioeconomic status as well. So that's a tough one.
Mm-hmm.
Well, I think it's an imperfect distinction, as you're pointing out. I think we're sort of in the early days in the Alzheimer world, so because we really have low rates of participation from people of color. And so we are required to track it, and we do track it because we want to recruit a diverse population of participants. And we're finding out some interesting things. I mean, at least at an initial pass. So women have a higher rate of Alzheimer's than men. We don't understand all the facets of that. We now have some better ways to see the changes in the brain with brain imaging. We can see the buildup of plaques made of amyloid protein and tangles made of tau protein. It turns out women in a prevention trial, in a one large prevention trial, have a higher buildup of the tau protein at the same level of memory impairment as men. We don't know exactly why that's happening, but so tracking that's important because we can get at least some initial insights. And in another prevention trial, they used a PET scan to show the buildup of amyloid plaques in the brain. African Americans actually had a lower rate of amyloid buildup than Caucasians. And I think it's the first time this has been reported. And so we don't know why that, even though there's a higher rate of dementia in African Americans, they seem to be building up, at least in the population that came for the study, building up the amyloid plaques at early stage less. So, I mean, we're going to get important information that will hopefully give clues that we can build on.
So let me just give you an example.
Excuse me.
Let me just give you an example of something that where race, it was just so shocking to me on a national level when we talked about cervical cancer. And there was a very good clinician. I knew him personally. He was a great guy, but he published a model of poor outcomes from cervical cancer. And in addition to the extent of disease, how well you did with your primary therapy, and all these other things that would make sense, including performance status, was Black. Being Black was considered part of the criteria for poor prognosis. And then they tried to design a study to prospectively evaluate that by stratifying patients on whether or not they were Black. And I remember being in a room when they proposed this, and I was like, you cannot use Black as a prognostic factor. You cannot. Being Black is not prognostic. It is substituting. It's exactly what was stated here. The Blackness isn't the problem. Access might be the problem. All right. You know, late presentation might be the problem, but Blackness is not a prognostic factor. And we were able to kill that study, but it went all the way. There are publications on the criteria in cervical cancer where Black is included as a prognostic factor in cervical cancer. And it was when you confronted the researchers way back when, they couldn't understand the controversy.
Yeah. You know, I think the big takeaway here is to quote Chandra Ford, like Dr. Wilson, is that race is less of a risk factor itself than a marker of the risk for racism related exposures that then tell you more information about what the person's experience is and like what they're bringing into this research that you're trying to do, right? And for whoever asked that question, or for anyone else who's interested in doing a deeper dive or conducting research in a better way, Chandra Ford and colleagues wrote this really great paper, 2 really great papers that we can send afterwards, called Critical Race Theory, Race Equity and Public Health Towards Anti-Racism Praxis, and also the Public Health Critical Race Theory Methodology, which sort of informs how you can, if you're gonna ask race from your patients, how you can use it and provide context. Because race, as we just mentioned, and as Dr. Dizon said, you can't, Blackness, for just to take your words, is not the issue, right? It's not the thing that's making it so that people are having higher rates of cervical cancer. It's all these other things that provide the context for that. So yes, we can send that out to y'all. Okay, so our next question is, how can we, and this is sort of switching gears a little bit, but how can we strategically support awareness of medical faculty as it pertains to the quote unquote blind spot? So many say they don't see color without realizing that diversity, equity, and inclusion efforts necessitates that you see color, see the absence, see the lack of representation of diverse groups in research, and the systemic impact of those gaps. We sort of talked about this a little bit, but.
Well, you know, I can start certainly. You know, I think part of it is, you know, not being afraid to point out the obvious, right? I was just on the phone with a friend of mine in Philly who was asked to, you know, get involved in a cardiology conference, for example. And she looked back at the prior year and they were experts. Everyone who was asked was an expert. They were all white. They were all men. And the blind spot was nobody saw that. You know, the organizers saw the content experts in their fields. Okay. The assumption you walk away from that is no one else is qualified except for this panel, right? It takes a lot to step outside of your comfort bubble, and we all have one where we know. I mean, you ask me, do you know anybody who does lung cancer? I can name 5 off the top of my head, right? And if you go to my conferences, it's the same people on the stage because there's a familiar, oh, he's very popular. They really like to hear from this person. It takes a lot to call someone out and said, you know, that same group of people, the same group of people who've been coming for the last 3 years. It's like, did you notice that you have no one here who's a woman? Did you notice they have no one here who's a person of color? You know, and when your colleagues are the ones who are saying something that is, you know, they're just completely blind to how inappropriate their statements are. To walk away from it would be tacitly to acknowledge it. So you have to be strong enough to call that out because you're not only speaking up for anybody around you who may not be in a position of power, right? But you're also educating someone else to, you know what? Not everyone thinks like you. And that's really the point.
Right, so also even just diversity in thought in these spaces is important.
Just to
Dr. Wilson.
Yeah, thank you. Thanks, Giselle. Just to piggyback on that, Don, so we have, I think I mentioned earlier that, you know, in emergency medicine, things are emergent, but there is a particular group of studies that are exception to informed consent studies, where we treat patients, where we get approval from the IRB, from the Institutional Review Board, to treat patients emergently for conditions in an intervention or experimental way, right? You know, patient has a massive brain bleed. We've spoken to the community and said, as a community, Providence, Rhode Island, we have folks coming from, you know, getting driven by ambulance from zip code X, Y, and Z. We've discussed this, and the community has an exception from informed consent for this devastating, life-threatening thing to be enrolled in this study. And as you know, a lot of academic emergency centers treat patients of color because we're centered in locations where patients of color tend to live. And so we have to be extremely careful about these interventions in folks who are having life-threatening issues, right? And so if there's no one on your EFIG group or committee or in your IRB who is looking out for that community, then you run the risk of, you know, having, I think, just kind of devastating impact on the community itself, but losing trust within the community, right? And so I think representation absolutely matters, you know, from community, from the researchers doing the studies, right? So I absolutely agree. It can't just be the same folks on the team, right? We need outside input.
I agree. I think a big thing is being mindful about being inclusive. It happened today. It's the same thing Don just described, where we were planning a national meeting, and we were a bunch of panels. It's really important. We might have a new treatment soon for Alzheimer's. We want to talk about the implications and how to roll it out. And halfway through, and the leader is a woman who is very dynamic and from Mexican background. And she says, "Hey, there's no diversity here. It's all white guys, and there are hardly any women, and there's no people of color." And one of the guys, and so we all recognized, we got to redirect the ship before it's too late. And then one of the guys, who's a terrific guy, says, "Oh no, we just want to focus on the science." What kind of answer was that? I mean, first of all, we can invite capable scientists who can speak whatever, and then also this issue of access and disparity is really important with the new treatment. And it's going to be an expensive treatment too. So it's in like the cancer realm. And so making sure there's access is a big issue. So anyway, it's mindfulness and then creating an inclusive research community. It's a problem. We don't have enough researchers in Alzheimer's. So please, all you brown, wonderful people of the future, consider working on Alzheimer's or related problems, because we could really use your help and you can make a big difference. But we also need to have a diverse group of researchers that we support their career and make them feel comfortable and at home as well. And I would love to recruit a faculty member at Brown who wants to focus on diversity research and health disparities in cognitive aging. That would be fantastic. But it would be a great complement to what we're doing.
That's a great transition to my last and final question. I see that we're coming up on time here. What is Brown specifically doing to recognize the issues of diversity, and how or what are y'all starting to do about it? Let's go with Dr. Wilson.
So first of all, we're taking just really a stock of who we enroll in our studies in our emergency department. We have an anti-racism and equity curriculum and a committee on anti-racism and equity, and our research group, our research committee is really actively engaged in evaluating all active studies and any planned studies from our department. And our institutional home for review for our IRB is really our Lifespan Corporation. A lot of us don't use the Brown system as much, but I mean, some of us do. And through our IRB, they do review your study to see if you are equitably aiming to enroll all patients. If you're excluding any patients from your studies, all your consent forms are translated in the language of the patient population we serve, which is primarily Spanish and Portuguese. There are other languages too, but primarily they really require that you're enrolling patients with limited English proficiency. And if you aren't, you have to prove that. You have to prove why it's necessary that your study continues without true diversity. And so those are like the systematic changes that we're taking. But additionally, we're just educating our researchers. We're educating our research assistants. You are approaching all patients equitably. You're not discounting someone based on the color of their skin or the language that they speak, just because you just don't think you can. And so we're actively reviewing those processes. And in addition, one of our research chair, Dr. Greg J, just added to our DSMB a DSMB and equity. So every DSMB that comes through is getting actively reviewed for equitable enrollment of all patients and equitable outcomes, right? Because the Data Safety Monitoring Board is looking at any data safety issues or safety issues with whatever intervention that you're doing. And so if you are having an inequity in your data reporting, why is that? And you have to kind of prove as a researcher why that is. And so I give Dr. J really big kudos for doing that in our department specifically, but as a Brown entity, I think Brown should take credit.
Thank you. Dr. Salloway or Dr. Dizon?
I think there are efforts. I think Steve and I probably could say the same thing since we're both involved in the creation of new centers. I mean, I think the message of equity and representation is first and foremost in all of our minds. It's striking that the first dean of oncologic sciences is Wafik El-Diri, himself an immigrant, exceptionally well trained with several patents under his and his network of people he knows and brings in represents the most diverse group of people that has ever been invited to Brown to speak. And I think that's really important. Every hiring decision or hiring announcement that goes out we are aiming for it all to be seen by as broad and as diverse a candidate pool as possible. Certainly, the network that I'm personally doing on behalf of people coming in, including Dr. Ash Alpert, who will be at the Cancer Center and a fellow in geriatrics. Themselves, transgender is going to be hugely important, and I'm excited to welcome them here. Dr. Sheldon Holder is joining from Pittsburgh, and an accomplished kidney cancer specialist and Black American. We're trying to diversify, and certainly I think, and having been at multiple institutions, this is by far the most welcoming oncology program I think I've been in.
That's awesome.
Yeah, so I would just echo the same. I mean, we have 6 major trials right now where diversity recruitment is a key priority, and we're being very carefully monitored for how successful we are. And we're devoting a lot of resources increasingly to this and building up our outreach team. And I already mentioned a community advisory board and a new relationship with Progressive Latino and satellite clinics. And whatever we can, and now I'm going to add in the advocate and the equity. And, I really want to learn. I think we really can learn from each other and share. And I hope the conversation will keep going where we share ideas, because it's going to take a lot of creativity to, make progress here and create that trusting environment that we talked about.
Yeah. All right. So with that wraps up our conversation. Thank you so much for being here and for answering all my questions and providing some insights. Y'all definitely got to work off of one another, and I'm excited to see what you do with what you learned, Dr. Salloway. Thank you for our attendees for being here, for asking so many questions. We did not get to all of your questions today as we thought we did run out of time, but we will answer those questions and send them over in a follow-up email with the links to Chandra Ford's articles that she wrote. So with that, thank you so much.